Good morning. Should we start?
Yeah.
Yes, sir.
Yes. Good morning. Today we are having a operative surgery discussion, which will be on the steps of Liechtenstein hernioplasty, followed by basic steps in laparoscopic hernia repair. Dr. Malavika Rao, who is a third-year junior resident at Apollo Hospitals in Calcutta, will present, and Professor Vimundu Vasu, who is a professor and head of surgery at IPGM SSKM, will moderate. Okay. Dr. Vasu, you can start. Yes, is an exam scenario with the.
Maravika, what is your case?
So my case is an inguinal hernia, and yes.
Okay.
Steps up Liechtenstein hernioplasty.
So you will start. You will say the Liechtenstein inguinal hernioplasty. Okay.
Yes, sir.
So open approach, that means anterior approach. You mean
Anterior approach.
okay. What are other anterior approach common? Other anterior approach you have to perform in sometimes.
So there is a reeve stopper repair. There is a plug mesh repair.
No. Commonly, we face such condition that we cannot do Liechtenstein. What is that common condition when we have to go for other thing? That means non-mesh hernioplasty.
Non-mesh. Oh, okay. With in strangulated hernias, or in there is obstructed hernias. There is.
So what did you do that?
So in those conditions, in strangulated hernias, if the bowel is, it depends on if the bowel is viable or not. If it's unviable, we'll have to do a resection anastomosis, which will be a clear contraindication to placing a mesh. If the bowel is viable and there is no infected, there is not.
Then when there is no scope for putting the mesh, so what
do you do? What technique you follow?
We do a herniorrhaphy.
What is that? Name some herniorrhaphy. Dr. Basu is asking what are the other alternatives?
Oh, okay.
Okay.
There is shoulders repair and modified Bassini's repair, which are where we overlap the leaflets of the transversalis fascia one over the other in order to achieve.
What you have seen in your practical life.
So in practical life, we just, in my institute, we just repair the posterior wall of the inguinal canal, and just without placing the mesh, we close the external oblique.
How?
You said modified Bassini. What is that? That is commonly done.
Modified Bassini is conjoined tendon is suture to the inguinal ligament.
Yes. Which continuous or interrupted suture?
Interrupted suture.
Interrupted suture. Using which suture?
Using a non-absorbable suture. Sir.
Yeah.
Okay. Now coming back to Liechtenstein. So what is the position of the patient?
As the patient will be positioned supine, both the arms can be placed either on at 90 degrees or on the side of the body.
What is the way of anesthetize the patient?
We prefer spinal anesthesia, but if the patient is very restless or anxious, sometimes sedation can be given, or sometimes even general anesthesia if there are contraindications to spinal anesthesia. And also local anesthesia is also available for open Liechtenstein's mesh repair.
So reducible inguinal hernia, which anesthesia is preferable, spinal, local, or generally?
We can do on a spinal anesthesia, sir. Or if the patient has too many comorbidities, a local anesthesia will also be feasible.
See, the standard literature always say that you always try to first choice is local anesthesia. And don't use spinal anesthesia, they specifically mentioned, because the hernia surgery, there is chance of urinary retention, which is aggravated by spinal anesthesia. But
yes,
in our practice in India particularly, all we use the spinal anesthesia. But standard teaching is you go for local anesthesia or general anesthesia.
Okay, sir.
Okay. Incision.
So the incision is a groin crease incision. We start the incision at 1 finger breadth above the pubic tubercle and proceed laterally proceed laterally beyond the deep inguinal ring, which is the 2/3, medial 2/3 of the abdomen, lower abdomen, over the inguinal ligament, parallel to the inguinal.
So you start from the pubic tubercle.
We start from one finger breadth above the pubic tubercle and extend it towards the anterior superior iliac spine, but only cover the medial 2/3 distance.
Okay. Then
we deepen the incision through the subcutaneous tissue. We will encounter three vessels, which is superficial circumflex iliac, superficial external pudendal, and superficial inferior epigastric. We can either cauterize or ligate those depending on the vessel size. And then we further deepen the incision until we reach the external oblique aponeurosis.
You see, superficial circumflex iliac does not come. Most of the time, if you are just deep beyond the deep ring, superficial circumflex iliac may not come.
Okay.
Other two may come. It's not superficial inferior epigastric. It's superficial epigastric artery. It's a branch of inferior epigastric.
Okay. Once we reach the external oblique aponeurosis, we make a sharp incision along the fibers, and then extend the incision medially to cut the superficial ring, and laterally to open beyond the deep inguinal ring in order to open up the entire inguinal canal. And then we will create a space in the below the external oblique aponeurosis for the mesh and the dissection. Then we will proceed to mobilize the spermatic cord.
So before mobilizing spinal cord, what structure you may encounter when you are mobilizing the upper lip and lower lip of the external oblique?
We might encounter the genital branch of the genital femoral nerve. Ilioinguinal nerve, which is there in the
and above. Above?
And above there will be the iliohypogastric.
Yes. Two important nerves you have to take care.
Yes.
Once we've created the space, we will start mobilizing the spermatic cord. After mobilization, we will have to skeletonize the spermatic cord and separate out the. If there is a direct inguinal hernia, we identify it. But even if we find a direct inguinal hernia, we always have to rule out an indirect sac, which can be done by skeletonizing. How
do you skeletonize? How do you skeletonize when there is no sac?
So we have to explore if there is a sac.
What do you do? You leave the spermatic cord has got some coverings.
Yes,
so what do you have to do to enter into this?
We will have to sharply dissect the. We can use a blade to cut the along the.
What is the layer you are cutting through? What is the layer you're cutting through now?
External spermatic fascia, internal spermatic.
No, it doesn't come in the inguinal canal. External spermatic fascia comes beyond the superficial ring. It's a prolongation of external big aponeurosis. In the inguinal canal, external spermatic fascia does not come. What is the structure you're coming? Sometime in young patient, this is very well developed.
Cremasteric muscles will be there.
Cremasteric muscle and the fascia. So you don't have external spermatic fascia in the inguinal canal itself.
Okay. The cremasteric muscles are sharply divided along the direction of the testicular artery and vas deferens.
And there is another layer. There is another fascial layer. Deep to cremaster. Internal spermatic fascia.
Internal spermatic.
Prolongation of fascia transversalis.
Okay. Once we have identified the vas deferens and the testicular artery and papilliform plexus, we will try to find the neck of the sac, and we go towards the deep inguinal ring to see if there is any sac. If there is no sac, then there's nothing to be done. If there is a sac, we will isolate the sac and open it up. If there is any content, after making sure if it's a sliding hernia or not. If it's a sliding hernia, then we will not open the sac. If it is just an indirect sac, then we can open the sac, reduce the contents, then once the sac is empty, we twist the sac at the neck of the sac and transect it with absorbable sutures.
Why it is necessary to open the sac and reduce the content? Can't you reduce the content by gently mobilizing the sac?
Yes, sir, we can do that as well.
So that is your motto. Why do you want to open the peritoneal cavity?
No,
And
sir.
why you want to ligate the neck? Is that necessary? Ligate the neck?
If we are reducing it without opening the sac, then it's not necessary to ligate the neck.
Because you are describing a reducible hernia, no?
Yes, sir. Okay. All right.
So first point, you have to say that yes, before giving incision, I have to reduce the hernia. Then you start the incision. This is the first step. And when the sac is, if the sac is very, very large, then only you cut and ligation of the neck, rather like a complete inguinal hernia.
Yes.
Otherwise, most of the time, we just reduce the content and invaginate the sac inside the abdomen. That is your, your technique.
Okay, sir. Once we have reduced the hernia, we will assess the patulousness of the internal ring. If it is too patulous, we can narrow it, the opening with non-absorbable sutures.
Where to give the suture? Where to place this suture?
Medial.
You want to tighten the deep ring, no?
Yes, sir. Yes, sir. So? Usually we will give it medial.
What is that repair called as? Narrowing the deep ring goes by an operation name. This repair is Little's repair.
Okay.
You narrow the deep ring. How? Okay. Dr. Basu has asked you, how do you do that?
With absorbable, non-absorbable sutures medially to the medial to the deep ring.
No. What below and what up? The sutures are taken lower down to a structure and above another structure. How do you narrow the deep ring?
No, sure, sir.
Below you take bite from the inguinal ligament.
On the inguinal, okay.
And above you take bite from the
conjoint tendon.
Conjointally, you just margin of conjoint. You don't take the conjoint itself because there is a point against.
See, the deep ring is on the. This is an opening on fascia transversalis.
Yes.
Okay. So the margin, that is the border of this ring, is definitely the
fascia transversalis.
And the lower border margins with what structure? What do we call that? Iliopubic tract. No. The deep ring, the lower border margin is merged with iliopubic tract. So better to say this upper bite should be the fascia transversalis and lower bite is the iliopubic tract.
Okay. Yes, sir. Okay. Should I proceed?
Yes. Okay. Now you deal direct hernia. This is your indirect hernia.
Okay. If it's a direct hernia, it will usually just present as a bulge. So we can just invaginate the contents, and then we plicate the posterior wall of the inguinal ligament, of the inguinal canal or the transversalis fascia with non-absorbable sutures. And that is the way we reduce a direct sac.
And then?
Once the plication has been done, and if any indirect sac that has been explored and reduced, we will create a place. We will ensure that there is enough space for the mesh placement. Then it is recommended that we change the gloves and make sure and clean the abdomen again.
What is your required space or your space for this thing? How to make this space? You have said very beginning that you will create this space, the upper leaf and lower leaf. Okay. So what is your required space?
The required space is 2 centimeters beyond the hernial defect. So 2 centimeters beyond the pubic tubercle, inferiorly the inguinal ligament. Laterally beyond the deep inguinal ring, we'll have to go 2 to 3 centimeters, and superiorly we can use blunt dissection to just lift the external oblique and create enough space for that. Then we could size the
It
mesh.
was the conjoint tendon area.
Conjoint tendon, yes, sir.
You see, the conjoint tendon is a muscular structure. So you have to dissect to see the clear transversal fascia whitish this thing sheet. Up to that you have to upper level your mesh. And the medially is very, very important, because the most of the time it is the notorious medial recurrence. So medial dissection, most of the hernia surgeon, they don't do, and the recurrence is there. So how much medially you have to go?
2 centimeters beyond the tube.
What is the structure there? How
What
do
is
you
the
find?
structure?
Rectus muscle.
Yeah, rectus sheath, not muscle. You don't see the muscle.
See, what is the limiting structure in medially? That is the linea alba, okay? So linea alba is the medial end boundary. So you have to clear that area. And
okay, sir. So we will use 11 by 6 centimeter synthetic mesh. In my institute, we use an Ultra Pro, which is vitral and monocryl or polypropylene meshes.
why is your choice? Why this is your choice?
Sir, Ultra Pro, which is vitral and monocryl, proline and monocryl together, is a lightweight mesh, which is.
What is the advantage and disadvantage of lightweight mesh?
A lightweight mesh is more can conform to the abdominal wall muscles. It's more comfortable for the patient, and the disadvantages is because it's lighter weight. It can predispose to recurrences earlier.
Have you read the literature? If you are using a vipro mesh, the vehicle is getting absorbed. The initial tissue reaction is less. That is the advantage of this lightweight mesh. But in long term, it is seen that the chance of recurrence is more with this vipro mesh. So it is not a very preferred mesh to be used. Okay, it was used at the beginning, but
controversial point, and also the EHS guidelines also does not recommend either lightweight or heavyweight, because it is a very controversial issue. Still, we prefer lightweight mesh, that is large pore mesh, in when we deal with incarcerated hernia in a clean contaminated wound. It is only the special area where you can use the lightweight or large sports mesh, but always we try to use the other one.
Okay, sir.
Okay. So almost now you place the mesh, and what is the important point here before closing the external oblique?
No, fixation of the mesh.
Fixation. Yes, fixation.
How do you fix?
The first bite is taken over the pubic. Once we place the mesh adequately to cover the right margins, the first bite is taken over the pubic tubercle and fixed at the pubic tubercle. Then we take a continuous sutures along the lower border with the inguinal, along the free border of the inguinal.
It is advisable to overlap the pubic tubercle area. So if you put the first stick pubic tubercle, how to overlap? So usually, which structure we usually take bite? What is the structure there?
Lacrinar ligament is.
Yes. You should see that the mesh overlaps the lateral border of the rectus sheath.
Yes.
That is the area you should see that is going beyond the pubic tubercle up to the lateral border rectus sheath. Okay. And then below you fix inguinal ligament. Medially fixed to what? Medial margin?
Medial margin we fix to the
rectus sheath.
To the rectus sheath, yes, sir.
One bite is good enough. And then above?
Above we fix it to the transversalis, the plicated transversalis.
You have not made a fishtailing of the mesh.
Okay. Laterally, we will cut the
Where do you
mesh
cut?
In medial 2/3, lateral 1/3 junction, and we extend the incision.
Not medial. If you take the mesh, it is lower leaf and upper leaf.
Yes.
Why do you split? In the middle
Up,
or more towards the lower side?
more towards the lower side, sir.
Yes. So 1/3, 2/3.
Okay, 1/3 to 3rd junction, and we extend until we the margin of the deep ring is felt, so that, or we can extend it beyond. Then we have to surround the deep inguinal ring with the mesh, and posteriorly and laterally beyond the deep inguinal ring, both the leaves should overlap.
Do you have a fixing stitch there?
And then we give interrupted stitches over there, sir. Only the inferior border we give continuous
No,
sutures.
no. After fisteling,
Yeah. You are creating a new deep ring. So this two split margin should be kept like that, or you like to put some suture beyond the deep ring?
I would like to put at least 1 or 2
Yeah.
sutures,
Yeah.
but doesn't need to be fixed till the lateral border. So inferiorly we will continue sutures, and then on the lower lip, and then the upper lip with the conjoined tendon, with the rectus muscle, and beyond the deep ring we will give interrupted sutures with non-absorbable suture material, and we have to ensure that it is not very tightly placed and it's not lying flat on the transversalis fascia. It should be a little convex, and the knots, that the sutures that we give should be air knots, in order to, even if there is nerve entrapment, it will not cause too much damage.
okay, but if you are dealing with the nerve that you cannot save, what you do?
We will do a sharp dissection.
Sometimes
Okay.
nerves are entangled in the large hernia.
Yes, sir. Then we will make a sharp cut and ensure there is no.
This you can do it only ilioinguinal. Keep in mind, you should not sacrifice the iliohypogastric nerve, because iliohypogastric has some muscular supply also.
Yes.
This you can do with the ilioinguinal nerve.
Yes.
Instead of strangling the ilioinguinal nerve, you can just cut it sharply. There will be small area of anesthesia where this ilioinguinal nerve supplies. Patient has small area of anesthesia where.
Oh, the suprapubic region, sir. And the middle aspect of the thigh.
Not suprapubic, no. Is the supromedial area of the thigh. Supromedial area of the thigh.
Okay.
Not suprapubic.
Okay.
And then closer.
Then we will close the external oblique aponeurosis, which with we use vicryl sutures, or absorbable, non-absorbable, and subcutaneously we will give sutures to subcutaneous sutures in order to make it cosmetically better. And skin is closed with absorbable subcuticular sutures, or skin staples, or ethylon as or interrupted sutures.
In chat box, someone has posted what is the concept of self-fixing mesh or self-dipping mesh? What is that? Have you heard?
I don't know, so I have not seen it.
Okay. So there are a lot of newer meshes available in the market now. You have a mesh which has got some bulb-like projections. So if you place it and just press on the structure, it will grip. It did not put any features.
It actually makes a Velcro patch.
Yeah.
Okay.
Velcro patch.
All right.
So these are self-fixing mesh, but difficult. To place open is fine, but laparoscopically to put this mesh is a difficult exercise.
I can imagine so.
Okay, so you have done the surgery. What are the post-op complications?
The post-op complications, most common, okay, intra-op, there can be bleeding, injury to the spermatic cord structures. There can be inadequate coverage of the mesh, or contamination of the field, injury to the vas deferens due to the spermatic cord, I said. And or there can be nerve entrapment intraoperatively.
What do you do in vas injury?
In vas injury, if it's recognized within intraoperatively, we should repair it. And
a 60-year-old gentleman, you'd like to repair?
In a 60-year-old gentleman, if there is prior consent, we can just leave it.
Even if there is consent, if you just injure the vas in a patient who is 60 years, you did not do that's all. You can just ligate both ends.
Okay.
Medico-legally, yes, we have to repair.
Okay.
And then post-op complications?
Postoperatively, seroma is very common. Then hematomas can happen with spinal anesthesia. Like Sir mentioned, there is a high chance of urinary retention. So if the patient has past history of LUTS, then we should or an elderly gentleman, then we can catheterize the patient preoperatively or intraoperatively. Then there can be in bilateral open inguinal hernia repairs, penile edema is very common. Then late postoperative complication, late postoperative surgical site infections, wound infections, mesh infections.
Yeah.
Then chronic neuralgia can be there. Ischemic orchitis. Then theoretically there can be osteitis pubis if the bite is taken on the pubic tubercle. It is very deep in cause ischemia.
If not done properly technically?
Can cause recurrence. Sorry.
Yes. Okay.
So we should now start what are the other approaches of managing inguinal hernia, particularly the laparoendoscopic hernia repair. So why this idea came for this laparoendoscopic hernia repair?
Laparoscopic hernia repair because it has lesser post-operative time. It has
Why? From where this idea came? You have said that this TOPA repair, NIHAS repair. So this extraperitoneal space is used for some other hernias, like usually bilateral inguinal hernia.
Bilateral, yes.
So
it is recurrent, yeah.
And the people are thinking if we use that space, so better repair can be achieved.
Okay.
And so, recurrent hernia, you already have breached the anterior wall.
Anterior wall.
So we go for the posterior approach in recurrent cases. And in bilateral hernias, it's easier and it's quicker to perform the dissection in the extraperitoneal space.
First, the indication of doing the laparoscopic hernia.
Yes. Indications of doing laparoscopic hernia. One is recurrent hernia. And the previous surgery is done by anterior approach, then we will go for the posterior approach. Secondly, if there is bilateral hernias. Third, if there is patient choice. Choice.
No. What is the current recommendation? What is the current recommendation for unilateral hernia? You see, 5 years down the back, it was gold standard of Liechtenstein. Now, what is the current literature which is coming up and throw some light on that? Is not a straightway Liechtenstein now. What is your impression regarding role of laparoscopy in a uncomplicated unilateral hernia?
So if the patient is affording, because
meaning my hospital is all free, no question of affording. It's your issue.
No. One point EHS, that is the European Hernia Society, mentioned particularly. These are the indications. In general, they have given the types of hernia and how to deal with these hernias. Yes. What operation you choose. This is standardized. They have given. You have to start that.
Okay. I don't know this. I don't know the answers.
Okay. This you have to read. Anyone who is going for the examination, this should be known to you. See, the first thing, the unilateral uncomplicated hernia, if expertise is available, laparoscopy can be done. Otherwise, you can go for open approach.
That is what I'm saying.
Okay, bilateral recurrent, yes, agreed. The preferable is laparoscopy. And one important point you have to add, that is the inguinal hernias in female, groin hernias in female, because many a times the femoral hernia is missed by open method, right? Yes. So these are the important thing. And if we choose the open repair, then you have two choices. One is tissue repair, one is mesh repair. Mesh you have already described. Tissue repair, Schultes. No other tissue repair is they recommend, right?
Okay.
Mesh, same. Lightweight and heavyweight, they have no choice. These are there are many recommendations. You have to read one by one.
Okay,
Then you can have the standard therapy, standard treatment you are offering to your patient. So you have the expertise available. Now you start the laparoscopic approach.
Okay. The laparoscope, first I will speak about the totally extraperitoneal repair. There are two methods. There is totally extraperitoneal and transabdominal preperitoneal.
Just you describe like you described Liechtenstein, you describe the steps of TEP repair. As you said, you will prefer to do a TEP. But then start with the basic things: anesthesia, position of patient, how do you go?
Okay. Anesthesia, general anesthesia will be required. The patient will be positioned supine with either the hands on the side of the patient or extended. The surgeon will stand on the lead surgeon. The main surgeon will stand on the side of the hernia or on the side of the larger hernia.
You need to put a catheter?
It's not recommended if the bladder is full when we do the dissection.
No. While doing surgery, bladder may get full. It is recommended that while doing a laparoscopic hernia, you should catheterize the patient. Maybe you can remove the catheter after the surgery is done, but catheterization is one step for a groin hernia repair laparoscopically.
Okay. The surgeon will be standing on the side of the hernia and the side of the largest hernia, and the assistant will be standing on the opposite.
Yes.
Regarding catheterization, it is written that either patient empty his or her bladder, or you put catheter. The thing is that why catheterization comes, because for the beginning, when the learning curve is there, their time is 1 hour, 1.5 hour, 2 hours. So the catheter is important. But nowadays, it takes only within less than half an hour. So there is no issue of catheterization. So better to answer, better avoid catheterization. It's just you say avoid. That's all.
Okay, sir. Okay. The monitor will be placed at the foot end of the table, and we will make a after plating and draping the abdomen, we will make a infraumbilical incision. The first 10 mm port, which is the camera port, will be infraumbilical. We go enter the preperitoneal space by retracting the muscle, the rectus muscle laterally, depending on the side.
You just tell me the step by step the first port.
Okay.
You have said infraumbilical where? Infraumbilical where you put the incision?
1.5 centimeters below the umbilicus. In the books say that towards the side of the larger hernia or on the side of.
But you have seen, midline incision.
Sir, we use a midline. We use midline, transverse incision in the midline, sir.
It's not exactly midline. You start from the midpoint to one side.
Yes.
You are coming on the wall of the rectus sheath.
Again, assist our TEP. Then you understand. Okay. So skin is.
You start in the midline and go on to one side. Don't take an incision just in the midline itself. From midline to one side.
Why do you avoid midline?
We avoid midline so that we don't enter the peritoneal space while
there is all blended layer. In the midline, all layers are blended. You want to make a space, you might go into the peritoneal cavity. So idea is to find a space behind the rectus muscle, between the rectus muscle and the posterior rectus sheath.
Yes, sir.
So how do you make this? How do you make this first entry? Make a transverse incision.
You make a transverse incision.
You need a special retractor. You need a special retractor to find the rectus sheath. It's a small S-shaped retractor.
Okay.
A small S-shaped retractor you use to retract the skin flap to find the anterectus sheath. Then what do you do?
Then we incise the anterior rectus sheath, give 1 centimeter incision, find the medial border of the rectus muscle, and then retract it laterally.
Good.
That is the
that is how you create this port first. And then what do you do?
Then we have to create
Muscle
the
is retracted.
preperitoneal space. The muscle is retracted. We
Malvika,
put in the
Malvika,
port.
I think you have not followed properly your the surgeon, because the first thing they do always retract the muscle laterally, put their index finger in the retrorectal space to make a good space with the finger first. Then he put on his 10 mm trocar, right?
Okay. Yes, sir. Yes, sir.
You again follow. These are the tricky tips.
I've seen it. I just forgot to mention it. So.
Okay. And then you need to
sir.
fix it. You need to fix this cannula. Because you made a little larger incision, the cannula might come out. So something is to be done. What is done? You take bites from the margin of your anterector sheath on either side. Go around, pack a gauze piece in the wound, and then tie this thread over the trocar, because otherwise the trocar will come out while doing surgery. Okay.
Okay.
So now you are in the retrorector space.
Yes, sir.
What is the first step now?
We need to create a preperitoneal space.
How?
So there are two methods. One is with a balloon inflation.
Balloon people does not use now. Balloon is now off.
Yes, sir.
You just start insufflation. You see, once you put the trocar, you start insufflation. Once you start, when the carbon dioxide goes in, it creates some space.
Yes,
and
sir.
then the next step is using the telescope.
The camera. Yes, sir. The telescope.
Not camera. Camera is outside.
Telescope.
Okay. Telescopic dissection. Yes.
So before starting for the giving all the gas, you just put some gas and put your telescope. Which degree telescope you use usually?
30 degrees.
30 degrees.
Initially, it is 0 degrees good enough to create the to do the telescopic dissection. Okay, because 0 degree, as you go in the telescope, now you see at the end where you are going. In 30 degrees, you see below what is being there in the floor. So initially, you can study 0 degree and then change over to 30 degree once you create the space.
Okay, sir. So we create the space.
So now tell us the landmarks. Where do you go?
The landmarks. We have to identify the inferior and the pubic tubercle, which pubic symphysis, which is called the whalebone, and below that will be the bladder. So we open up the cave of Retzius first. Then we'll have to identify the inferior epigastric vessels, which are on the anterior abdominal wall.
So, you are in the below the symphysis pubis. Why you are jumping, going up? Huh? There are other spaces to create here. Then you go up to see the inferior epigastric. This step by step.
Yes, sir.
No hernia surgeon do one from one part to another part jumping. No, this systematic design.
What is called as lighthouse? Lighthouse kahan hai? Lighthouse? What is the lighthouse? Lighthouse is?
I don't know.
When you do operate, you find a shining structure. That structure is Cooper's ligament attached to the pubic ramus. That is the first thing you see. Symphysis is in the midline. Don't go straight to the midline. You just close to the midline and try to see the shining structure. That is the Cooper's ligament over the pubic ramus. That is the first thing you look.
Okay.
So that is the medial part. And now,
medial part.
Once you have created some amount of space, what is your idea? Where do you put the next ports? There are again different surgeons use different ports. Where do you place the next ports for that?
The second port is placed in the midline, in the midpoint between the pubic symphysis and the first infraumbilical port. It's a 5 mm port that is used. Then we will dissect the one. Immediately we dissect the cave, create space in the cave of Retzius. Then we proceed to the lateral dissection, lateral area dissection.
Lateral to space is which space?
Space of Burgos.
Yes. So what is your limit of lateral dissection?
The complete limit will be till the anterior superior iliac spine, sir.
And you want to see psoas muscle also, right?
Psoas muscle, yes.
You see, it is just medial to anterior. The psoas muscle is the boundary of orifice. You should go just beyond the psoas. So for going to that place, you need to make another port. You put the second port, create space for the next port to be placed. So ultimately, you do the surgery with 3 ports.
Yes, sir. The third port is placed as laterally as possible, but before medial to the anterior superior iliac spine. Just
You mean you will place? There are 2 school of thought. One, people are all 3 ports in the midline.
In the midline, yes.
The other people are in the midline is a camera port, create space on either side in the retrorector space, and then create 2 lateral ports. It's not that you put one midline port and make another lateral port. You can make 3 midline port straight away, and that is one technique for doing the TP. Or you can make 2 lateral ports.
Okay.
How 2 lateral ports are done, Dr. Shah? Because opposite side I have not dissected. No?
Yeah, once you are going for unilateral hernia also,
yes,
you can, as you go to the retrorector space here, the creating space on the lateral side is not difficult, because just beyond the arcuate line is free. There is no posterior rectus sheath, so you can just create a space between the rectors, and very too much lateral is not required. It is just lateral to the camera port, because some people are doing with this. Some people are comfortable with the midline port only, 3 port in the midline. Okay, so what do you have to dissect now? There are 3 areas to be dissected: medial, lateral, and the middle.
Once you've created the space and identified the inferior epigastric vessels, when you have to look at the internal ring and at the site where the deep inguinal hernia would be. So deep inguinal hernia should be reduced first because it's easier to reduce. And then we skeletonize the spermatic cord.
Finding out the landmarks you created now, where is the direct hernia, where is the indirect hernia? You have now shown us the Cooper's ligament. So from the deep ring up to the midline is the area of Cooper's ligament. There lies the direct hernia.
Yes, sir. Medial to the.
While dissecting this space, you can dissect the direct hernial sac, and you will find what is pseudosac.
A pseudosac in a complete inguinoscrotal hernia, there will be pseudosac is the sac that comes in from the scrotum.
It's got to be complete. Even incomplete also, as you pull this hernial sac, you will find a projection of the first unbraces laterally. That is the pseudosac. You strip it towards the scrotum. It need not be a complete hernia. Even an incomplete hernia may have a pseudosac.
Okay.
And then how do you dissect the indirect hernia now? In a TP approach.
The indirect hernia, we have to skeletonize the cord with a mixture of blunt and sharp dissection. And the aim is to make sure that the vas is dissected out medially and the pampiniform plexus laterally. And the entire sac should be.
You are in the which triangle? You are in the triangle of doom.
Doom,
right?
Yes, sir.
Because it is the inverted Y triangle. Inverted Y, one
yes,
is spermatic here in these cord structures on. So you have to dissect very gently and very cautiously so that you will not injure the
external
yes.
iliac.
It's a very long hernial sac going up to the bottom of the scrotum. What is the strategy? You know that this hernia is a complete going at the bottom of the scrotum. You start dissecting near the deep ring. Would you venture to bring out the fundus to the peritoneal space?
No, sir. We can. Yes, I understood the point.
Yeah.
We can. If the contents are reducible, then we can transect. Once the sac is empty, we can transect the sac, leave the distal end open, and close the proximal end. But this can be difficult laparoscopically. Technically difficult.
You can do it. No. You cannot.
No, we can do it. We can do it.
If it is a complete hernia, it is not wise to venture to keep on trying to bring the fundus to the peritoneal space. It is very difficult because it's up to the bottom of the scrotum. Some expert can do it, but most of the time, if it is a complete hernia, you dissect the sac free from the cord structures, go around, pass a ligature to the proximal side of the sac, and transect the sac. Leave the distal end open. See that there is no bleeding.
Okay.
So that is a strategy. How far up you do the dissection? Now you have the sac in your hand and start dissecting. So what is the upper limit of dissection so that you can place a good mesh? It's not 6x3 to little larger mesh. How far up you go? What is the recommendation? You have a deep ring. From
yes,
the
sir.
deep ring, the testicular vessels and the vas is emerging.
Yes, sir.
And then how far up you should dissect?
The
That means
dictum
towards
is that we should retract the sac completely and it should be within the peritoneal cavity. And the peritoneum
You are
should
in
be
the
at least 3 to
peritoneal
4
space. You see,
centimeters.
you are in the peritoneal space. The recommendation is you dissect upward, usually 5 centimeters from the deep ring or the point where the vas and the testicular vessel diverges. You see, after the deep ring, the vas goes medially and testicular goes laterally. So it should about 5 centimeters. It may vary in different individuals, but approximately 5 centimeters. So that you should proximally.
Okay. Okay.
And how far go below as you take the dissection? You medially go to the retropubic space, and laterally what is it area? And people try to exclude any other hernia there or not.
The psoas muscle laterally, sir.
Psoas muscle laterally below. What is the area below the pubic ramus? What is that area called as? There is a foramen there also. That is the obturator foramen. You need not dissect all the obturator vessels and nerves, but you dissect below the pubic ramus so that you can the mesh also covers the area of the obturator foramen.
obturator foramen and also femoral hernia there.
And the femoral hernia is above between the Cooper's ligament and the inguinal ligament. That is the area. As you dissect the pubic ramus area, you also clear the area of the femoral ring. Okay.
Okay. Okay.
So if you feel the adequate space is made, the next job will be what standard mesh is placed in our Indian population, the average height?
15 by 10 centimeters.
15 by
mesh.
12. 15 by 12 is a usual mesh you use for our patient population. So you have to trim this 15 by 15 mesh. And then?
And then we insert it into the preperitoneal space through the infraumbilical port.
Yes.
And then we, once we place the mesh is placed. If it's a unilateral hernia, it has to go beyond the midline, and inferiorly it has to overlap 2 centimeters over the whalebone, and laterally it must go beyond even a deep inguinal. And we place,
not
we
only
fix
deep,
the mesh.
Go laterally, it is going beyond the psoas.
Psoas, okay.
Beyond the psoas. And how do you fix the mesh now?
The mesh can be fixed with staples.
Again, there are a lot of people. If you are doing a TEP, some people will say mesh fixation is not required.
Not fixed.
Or some people will say at least one mesh fixation to the Cooper's ligament is good enough.
Yes, sir.
Okay, for TEP, but TAPP need little more fixation.
Okay. Yes, sir. Then after we fix the mesh, if it's a bilateral hernia, then we will place 2 meshes, one on either side, and medially in the midline, both meshes should overlap. And once that is done, we do an observed desufflation to ensure that the mesh lies flat. And we should additionally also try to make sure that the scrotum is also decompressed at the same time. And we remove the ports and close the sheath as we close any port site.
Yes. Okay, I think we have covered this. You see, we are given a card in the exam. You have to answer. What I prefer in the exam is you divide the operation into salient steps, making the first port, placement of subsequent port, creation of medial space, creation of lateral space, decision of hernial sac, and then placement of mesh. So if you divide the operation into small sub-steps, you can describe each of the steps properly, rather than saying one paragraph in a operative session. You can divide the steps into salient subheadings.
Okay, sir.
because
Okay.
you have to tell the principles of the operation and major steps, step
Yeah.
by step.
Yes.
Okay, sure. All right.
Malavika reads well. Okay, good.
No, I think she has some practical experience also, TEP.
No, she has
TAP,
good
yes,
profession.
sir.
Yes.
Your surgeon doesn't do TAPP?
TAPP, sir, we don't do in our
You
institute.
tell me one indication of TAPP. Even if you are
Sorry.
a lab hernia surgeon, in some situation you may be forced to do TAPP. When?
If during TAP repair we
No,
open
before
up
that repair.
there's a
Before
large,
that repair even when pre-op you can take a decision. Yes, this is not a patient suitable for TEP.
if there is any preperitoneal radical prostatectomy that has been done.
No.
Which
The radical prostatectomy is contraindicated for both.
Okay.
This is irreducible hernia. Try to understand.
Okay.
In TEP approach, it is difficult to reduce the hernia. So if it is irreducible hernia, it is better to earlier irreducible hernia is a contraindication for lab repair. Now, if you have a TAPP approach, you can reduce the hernia under vision. In TEP, it is difficult. In TEP, you are not opening the sac unless required. Okay, and it's difficult to reduce the hernia in the TEP approach. So irreducible hernia, one indication is TAPP. And another thing you're trying to say is while doing TEP, you made an entry into the peritoneum and you are losing space. You cannot work at all. But now people are become more expert. When with the peritoneal entry, they put a varisonal in the peritoneal cavity and keep on doing. Okay, so that depends on the expertise.
Okay.
Okay.
Another important indication you have to tell nowadays, robotic. You can't do TAP robotic. Can't do.
Yeah.
You have to do TAP robotics.
Yes.
So people are doing robotic hernia, so all that they are doing.
No, this will come. People are doing. Just wait. Okay, Malvika, thank you.
Okay. Thank you, sir.
Thank you. Good.
Thank you.